I grabbed the PowerPoint, which was originally, oh, I don't know how many slides. Yeah, I did not get any, I didn't get called back or contacted back about my space on that, so I'm gonna have to get Melissa on that. But anyways, I don't know how many slides there were. Horrible PowerPoint, but I've hidden a bunch of slides that we will not have to go over. And in other slides, I did some things to kind of speed things up a little bit. But let's go. So gastrointestinal tract, everything from mouth to the other end is the gastrointestinal tract, also called the alimentary canal sometimes. So our objectives today illustrate the anatomy. Really, now you, I hate you. Here, in fact, let me unplug this. Plug my just regular mouse back in. I don't think I'll need the my writing pad today. At least I won't need it much. Okay. You know, sonographic evaluation of the GI. 5 sonographic layers of the bowel wall. They like talking about that. Esophagus, stomach, small bowel, appendix, and colon. Disorders of all those as well. Peristalsis or peristaltic activity with cine loops. GI tract movement is valuable. We could probably pull up something on peristaltic. Tract movement or peristalsis is valuable information. We don't usually look at the GI. As you guys know by now, it's filled with air and so often just not well seen. Even when it's not filled with air, it is not particularly pretty to look at, but we can get some information from it. All right, so we have transabdominal, which is what we are accustomed to so far. You know, we could look at you know, pelvic pain, because sometimes, well, we have intestines all the way down into the pelvis, of course, and a cause of fever. We could actually, that's not really a good script. You can't say on a prescription has a fever, get an ultrasound. It doesn't quite work, but we can discover a cause of fever. Rebound tenderness, that's specifically with the appendix. Any kind of palpable masses and follow-up abnormal from labs, CT, MR, and other radiography type stuff. And there's endoluminal, not widely used by sonographers, performed more like by endosonographers and gastroenterologists using specialized endoscopes. But it's valuable for us to at least look at a few of these images and figure out how they see the world. Ultrasound is interesting. Endoscope, specifically designed transducer at tip to acquire sonographic images within lumen. You know, it looks as it's a very high frequency. It does not, you don't put into a lumen and see 6 centimeters, 10 centimeters out. You're usually looking within a few centimeters. And if you do both transabdominal and endoscopy at the same, well, on the same patient, not at the same time, but on the same patient, you get, you can increase your knowledge of what's going on. And that's pretty, you know, pancreaticobiliary system, paraluminal lesions like lymph nodes, so lymphadenopathies, ascites, which we could easily see with our transabdominal left liver lobe lesions. Try to find reasons for rectal bleeding, although that would not be something that they would send to CT because ultrasound, they'd more likely send it to CT for that kind of diarrhea. Yeah, diarrhea actually, one of the you can have diarrhea with gallbladder issues. Hematochezia, that's actually bleeding or passing blood stools, bowel obstructions, change of bowel habits. A lot of these things, guys, are not really our forte. They're probably going to go somewhere else first. Fine needle aspirations. We could do a needle introduced through actually the endoscope to sample masses or enlarged lymph nodes. So an endoscope is going to have a multifaceted, it's going to have a ultrasound transducer, a tiny transducer, mechanical, that spins around. But right next to that, they're going to actually be able to find put a needle all the way down through the scope itself and be able to do an FNA, a fine needle aspiration, right there at a mass. So that's pretty cool. Endoscope is also for rectum and anal sphincter and stage and manage rectal cancer. I guess we could also see, let's make sure we get our terminology. I certainly hope they're not using the same endoscope here as they one on the one going down the throat. That's interesting. No matter which way I go. Okay. Yeah, because a sonoendoscope introduced into the esophagus, I pray to God, is not the same one they introduced into the rectum, but I don't know. Anyway, but these are endoscopes. These are very long. They are fed through a lumen. And then there's also a transrectal, which is a similar in shape and scope and size as the transvaginal, which I'm sure you guys have all seen on the in the lab. So when I say endorectal sonography, they're not really talking about endoscopic. Endorectal is just a transducer similar, like I said, to the endovaginal, and they could evaluate the prostate gland. So by the way, I never had to do this. Never had to do it. All the hospitals pretty much punted on that where I was from, and they sent it all off to the doctors. The type of doctor, the name is escaping my brain for the moment, but other doctors, and sometimes their technologists would do the prostate exams. Oh, but lucky for you guys though, they do them in the hospitals in this town. So endovaginal transducers can locate and document appendix in females. Can be especially helpful with large body habitus. And so I have found the appendix in females with an endovaginal, and it's actually very useful. But because the appendix oftentimes is right there in the pelvis within centimeters of the ovaries, which we're already looking at. So the GI is approximately 30 feet long. I've heard, I can't remember if this is true or not, but I've heard that if you completely flatten out every villus, every fold, if you completely flatten it out, it would be able to cover an entire football field. And that's because you have to maximize the surface area in order to maximize your nutrient gain from food. Originating at lips, terminating at anus, the anatomic drawing of GI tract from mouth lips. Yeah, no shit. Excuse me, no kidding. So, you know what? I've got another image of this. Right, and I am going to jump to the other image in just a second. So, this is these next two slides. We're going to talk about the layers. The 5 layers. So the mucosa, or they're calling it the surface layer. Well, that surface is like the inner surface, right? That's where the business end is. And so the innermost layers within the mucosa, there are the epithelium, the lamina propria, that's more of a connective tissue, muscularis mucosa, thin muscle tissue, because it's not the muscularis layer, but really epithelium, that's the part that is in contact with the stomach and intestinal acids and food and such. Mucosa is epithelium, lamina propria. It's this, so they kind of gathered those two together. Submucosa, thick, highly vascular, serves the mucosa, so that's kind of the blood supply and everything. Muscularis, stomach has 3 layers with a smooth muscle with a smooth muscle tissue, 2 layers, and remainder of GI tract. The muscularis, that's what's going to make it a muscular tube. And so this is a thick layer, and the serosa, the thin epithelial layer on the outside. So what's important for us to understand is how this looks sonographically, and we got some images. Actually, I'll just use the images on the next slide. That goes from hyperechoic, the innermost interface, the epithelial layer really is hyperechoic, and then hypoechoic, hyperechoic, hypoechoic, and then hyperechoic. So that second layer was the mucosa, hyperechoic, submucosa, hypoechoic, muscle, the muscular layer, and hyperechoic serosa, the outside layer. So actually, you know what, I will bring up the, so same image, didn't come across too well, it was low quality image, but maybe I can do a little mouse pointing out and such. So our mucosal surface, we have all sorts of folds, even on the smaller level, there's gonna be little tiny villi. What the heck color is that? Little villi sticking out. Little villi means fingers. So those are sticking out. Those are microvilli. Then you have some more of these larger folds as well. And depending on where you are, whether you're in the stomach or other parts of the intestines, they have different names for these folds. But epithelial surface, this line of cells is the epithelial surface, and then you have the this is mucosa, submucosa, muscularis. Here's most of our muscles are in this area here, and then the serosa, basically the outside layer. You see, we have visceral peritoneum on the very outside of the serosa, and so that means is, now this is a pretty cool actually image if you think about it. This is a endoscope. So I know we talked about this the other day, but it's worth mentioning again. This endoscope looks in all directions. That's why the transducer itself is dead center. Normally our transducer is up here, and we're looking down from that, but no, this transducer is dead center, and we're looking in all different directions. So keep that in mind when you look at one of these. This loop of bowel, or whatever it is there's fluid in here. So that's why, now you have some reverb artifact, circular reverb artifact, that's probably just bouncing a little bit off of the transducer face itself, but you can see that this all is anechoic, and therefore all most likely simply fluid. Now we have our 5 layers here, so it's echogenic. Let's get even closer. I don't know if this is how this is gonna look. Not great, but close enough. Echogenic, hypoechoic, echogenic, hypoechoic, echogenic. That last echogenic layer is hard to see because it's pretty much echogenic out here as well. So this layer is difficult. You can probably see it right here. Not too bad. All right, and let me just pull up this. Yeah, this image down here is stomach once again. Hard to see all the layers. Let's see. 1, 2, 3, 4, 5. So echogenic, hypoechoic, echogenic, hypoechoic, echogenic. And then yowza. And then once again, this is stomach filled with fluid. This looks like a baby. And so 1, 2, 3, 4, and 5. Really hard to see on this baby. Very thick muscularis on this baby. All right, let me just pull it over to here. Well, actually, let's do more than pull it over. I think this will be the last I even use this program. I don't think we need it anymore. Stomach. And when they talk about the antrum of the stomach, talk about the antrum of the stomach, they're really talking about kind of this area here. When they're talking about the pylorus, or the pyloric sphincter, is here. That it's cut away, but that is a muscle that keeps food and drink in the stomach for a little while and then allows a little bit out at a time. So we're not just shooting from the stomach right into the duodenum. The duodenum is going to control how much is going in. So like when JP's taking a drink, it doesn't just go shooting past. Anyway, so pyloric sphincter, antrum of the stomach, fundus of the stomach up here. When they talk about the lesser curvature, this is lesser curvature, this is greater curvature there. Keep in mind, in order to draw these pictures, they have to really separate everything. There is no separation between liver and duodenum and stomach and pancreas and more duodenum and transverse colon and all these intestines. There is absolutely no distance between them at all. They are squeezed in absolutely tight unless we're filled with ascites. And that would be the only time that you're able to see these things as really separate entities. Now, you know when you're looking at stomach versus transverse colon because there's two little bit different air pockets. But we're also going to talk about the duodenum a little bit. Let me just stay on here. The very first part of the duodenum, it's right there. I'm actually getting a cramp. Second part of the duodenum, third part of the duodenum, fourth part of the duodenum, and then it turns down. So 1, 2, 3, 1, 2, 3, 4. Well, we'll find out, won't we? Okay, I gotta switch hands. That's a first world problem right there, is when you get an injury from using a mouse. All right. Yeah, that's more the same. Okay, sonographic pictures. Image fluid-filled stomach demonstrates 5 visible layers. Endocavity. Image of bowel layers. That does not look like an endocavity to me. But you might not see every layer every time, and that's important to know. But let's see. 1, 2, 3, 4, 5. We actually can see all 5 in here. Because echogenic, that's an easy one. This hypoechoic, well, I'm not sure. I'm not so sure. There's a little bit of, is that one hypoechoic piece or not? But in any case, it's not important that you see all 5 every time. But when you are using a high frequency transducer and on a patient who's capable of handling, the body habitus is capable of handling a high frequency transducer, then you do want to see all 5 layers. Like I said, I don't understand how that's a endocavity though. Maybe I'm just crazy. Okay, so the esophagus itself is something we are not going to see a whole lot of. You see it when you're doing the thyroid, and you look, usually as someone's laying on their back, the esophagus slides a little bit off to the left. When they're standing up, it might be dead center behind the trachea, but when they're laying down, it's usually off to the left side. And we could see it right there. You could see it possibly through. Well, you can see it right there anyway. Most sonic, if you're using an endoscope, then yeah, you see it beautifully. But our transducers are not going to see it very well. We can see the esophageal junction, the esophagogastric junction in the stomach, especially if a large left lobe. We're not talking about like an unusually large left lobe, just a large, a left lobe that's big enough for us to be useful for us. Given an erect patient, that means sitting up, JP. Water to drink allows images of distal esophagus. So sometimes we do serve water to the patient, have them drink, and we could see the esophagus. We could possibly see the stomach a little bit better as well. And actually, we use that with babies sometimes. Now, I am not 100% sure why in the book and on this it says a longitudinal and transverse image. These are both longitudinal images. It looks like the same patient too. We start off with a esophageal junction in this section. It's kind of more or less circular because it's probably turning. It's coming through the trachea right here, through the muscular tissue that helps us breathe. For God's sakes, Kurt. By the way, I didn't sleep last night. I had a power drink in the afternoon and stayed up half the night. Really fun. Diaphragm goes through the diaphragm at this point and immediately turns off to the left, going towards the stomach. And so that's probably why we're seeing it as a circle right here. In my opinion, the distance between the aorta here and the liver is a little bit increased, which could suggest that this person might have a hiatal hernia, maybe a little bit too much tissue in here. But that's kind of equivocal. It's hard to say. Here, it looks like we have a little bit of trachea again, except we've gone farther off to the patient's left, and now we're getting into really this stomach here. So a little bit of trachea, it seems like, and then we don't see any connection, and then there's stomach. Esophageal cancer is rare, only about 1% in the United States. Most of them are squamous cell carcinoma. That's more common in the mid and upper esophagus, and I'd have to look at the what kind of cancer you get from chewing tobacco, but probably that. And surprised with the incidence of chewing tobacco that the incidence of esophageal cancer is not a little higher. Adenocarcinoma is another one that's a little bit less common. Other tumors are rare carcinosarcoma, lymphoma, mucoepidermoid carcinoma, adenoid cystic carcinoma, glomangioma. And I'm not interested in you guys memorizing that list, but it's just a good idea to look it over and have a slight, have an idea that that's more than one cancer is possible. most common benign tumor of the esophagus and other parts of the GI is the leiomyoma. Now, you're going to find out next semester that is also the name of a fibroid. So uterine fibroids are leiomyomas, and they are benign, and it is a tumor of muscular origin. So that is all that is. Yep, we already mentioned that. Esophageal junction can be imaged posterior to the left lobe, anterior to the aorta. So we could see hiatal hernias, and that's really just a little bit too much tissue in that area. Esophageal varices, so these are super important. If you're back, I don't want to go all the way back to that picture, but if you're in that area and you see a bunch of blood vessels, that is big news, and that patient's in mortal danger. So definitely don't want to skip over that. If uncertain whether a cystic structure in the left upper quadrant represents stomach, give patients some water. You'll actually see it going into the stomach. If you need to view the stomach, you can let them chug some water. Actually, through a straw is better. When you give them water to just drink, they'll swallow air. Whereas if they drink through a straw, they're less likely to swallow air. I had a patient who was on a drink as much water as you can diet, and she had so much water in her stomach and her intestines that, and I was a student at the time, so I wasn't that familiar with everything. I couldn't understand what I was looking at. I would just see, as I was looking at the spleen, I could see through the spleen, all the way through the stomach into the liver, because normally that's all gassed out. You don't see the liver from the left quadrant, the left upper quadrant or left flank, and I could see all the way through it. So sometimes, yeah, your patients will have a lot of water in their stomach. That's a possibility. So, the stomach contains air. It's not exactly, it's usually, stomach is in our way. And it's in our way because of the air that's in it. But if you place the patient the right lateral decubitus position, it moves fluid into the antrum. In other words, the pyloric region. In other words, you just roll them up on the right side. That's all the lateral decubitus means, is roll them all the way up on the right side. Left lateral is the other side, of course. Now, I've not done this with a whole lot of adults because I've never really even been asked to look at the stomach in particular. Babies, on the other hand, pyloric stenosis is a big thing that we look at with babies. And so babies, I do have the mom or dad roll the baby up on their side in order to help get fluid into the antrum, and so that I could see the pylorus a little bit better. Left lateral decubitus improves visualization of the fundus, of course, because you're laying on that side, the water is going to run downhill. So the fundus is medial to the spleen and anterior to the left kidney. Body and antrum lie posterior or inferior to the left liver. In fact, let me do something here. Let me, not really. I hate you. I just hate you, I suppose. All right, well, I'm just going to move things around here because I'm not going to mess around with this. All right, fundus is medial to the spleen, body and antrum lie posterior or inferior to the left liver lobe, anterior to the pancreas, and medial to the gallbladder. Okay, so I would like to look at that and see what that. So Spleen on this person is going to be, of course, pretty much over here. So yes, medial to the spleen. Spleen is lateral to the stomach. Kidneys, very round kidney is also here. So stomach is medial, what did they say? And anterior to the left kidney. So this, yeah, this kidney is a retroperitoneal organ, so it is more behind. But I would say it's medial and anterior to the left kidney. What's the next thing we said? Body and antrum lie posterior or inferior to the left liver lobe. Body and antrum lie posterior or inferior. Posterior or inferior. So yes, posterior and inferior. This shows inferior, right? Because we're looking at the body straight down. That's not exactly an ultrasound view. If we were to see this in ultrasound, we would have liver on the left. It'll say we're sagittal. Let's see, I got my transducer right here. We're going to see liver on the left side of the screen. The stomach is going to be more towards the right side of the screen, and it's unrealistically far apart. That is inferior. It can be snugged up right underneath that liver, and then therefore it would be posterior. Anterior to pancreas, trust me, it is always anterior to pancreas, and that's a pain in our butts, in our collective butts. And medial to the gallbladder and porta hepatis, gallbladder's here, and so yes, anything to there would be medial to the gallbladder. There, antrum and body often appear as a target. Okay, let's get rid of this guy. Antrum and body often appear as target-like structure inferior to the left liver lobe on longitudinal sonograms. We saw that picture before. You just had a circle of a stomach. Well, that is that the. Now, you know what? That was the antrum. I have to think about that. Probably actually more body than antrum. Larger left lobe, yeah, we already mentioned how the larger left lobe helps us. The wall changes with distension, obviously. So a non-distended, in other words, empty stomach, it could be 4 to 6 millimeters in thickness. If the stomach is distended, then more like 2 to 4. Well, you're just stretching it out, so that makes sense. Thickening greater than 1 centimeter is probably or considered cancer until proven otherwise. When fluid is present, rugal folds. And so in the stomach, it's rugae or RuPaul is gay. No, rugal folds and posterior wall structures can also be visualized. So there is a stomach filled with water or fluid in any case. On that person, we are not seeing the wall as hyper, hypo, hyper, hypo, hyper. We're pretty much just seeing a echogenic wall. It doesn't look healthy. So I think there's something wrong with that wall, and that's probably why it is 100% echogenic from the interior. From there all the way out is one echogenicity, and that is unusual. Could be the quality of the image too, so you got to be careful what you call, but I think that's an unusual, and it looks a little thick too. But yeah, well, short arrow identifies hyperechoic mucosa, long arrow contents. Well, hyperechoic mucosa and everything else. I don't know how I touched that. We've seen this picture before. So acute dilation can occur. So oh my God, there was a couple of ladies. and neither one of them you would expect it. Let's just put it that way. I had one lady in particular who I don't know if she was one of uh, these Olympic food eaters. You know, these people who go out and eat as many hot dogs as they can at once. Those people purposely stretch their stomach. Well, this lady she had a mostly fluid-filled stomach, and it went from left upper quadrant, just below, at the chest level, all the way down to into her pelvis, and she was otherwise normal appearing older lady, and just a gigantic fluid-filled stomach. Oh no, and then the other lady was not stomach. What am I thinking? It was. Well, I'll bring her up later because it was colon, and we talk about the colon at the end, ironically. So tumors, ulcer disease can obstruct the outlet. Gastric outlet is the pylorus. Pyloric muscle hypertrophy is rare in adults. In fact, I've never even heard of it, but in babies, it's one of the things that we do, and it's not terribly rare in babies. So observing gastric peristalsis, in other words, movement of the muscular tube, can differentiate atonic from obstructive dilation. So atonic just simply means, for whatever reason, whether it's nerve damage, some kind of viral infection, gosh, we have a whole list, and I can't think of any of them. But it's just simply not moving. Whereas obstructive dilation is, of course, from an obstruction. Volvulus is a cause of a special kind of obstruction. That's when the intestines twist, and so they'll twist and torse around, causing an obstruction. And there's actually a really neat way of seeing that, and I found it once, and I don't know if I've ever told you about the biggest jerk I ever worked with. In fact, I'm going to write it down. Don't want to forget to talk about that. I'll talk about that I'll talk about it in a second. But it was that doctor who I just no one got along with him, but I showed it to him, and he said, "That's normal, Kurt." I said, "No, it's not." Anyway, I'll go to bed early tonight. So gastritis is simply inflammatory reaction of the gastric mucosa. Chronic gastritis can be several factors. May present as enlarged rugal folds. I think we have a good image of that, with generalized thickening of mucosal layer. This is a great picture. And oh, look, so this is definitely the stomach, because here's the liver. Right at the tip of the left lobe of the liver, that's the inferior tip. And so this little stomach here, and that's just awesome. This is all the little rugal folds going in there, and these obviously those are designed to the folds open when the stomach is filled. So they're obviously there for a reason. And then we have a very, very thick wall, especially anteriorly here. So inflamed stomach demonstrate thick and hypochondrial mucosal layer of stomach. Yeah. Let's actually echo hypo. I don't know. Ulcers is a break or ulceration. Remember, we use the term ulceration in carotids when we're talking about a break in the plaque. A little hole in the plaque, that was an ulcer. A peptic ulcer is a hole in the stomach. or duodenum for that matter. Not necessarily all the way through, but in the protective mucosal lining of the lower esophagus, stomach, or duodenum. We're probably not going to see the hole itself, but wall thickening, edema, thickening of the gastric mucosa in the area. So complications is that it can lead to a perforation. And so obviously that's really bad because now you have a hole between your GI tract and your insides, and that is never a good thing. Duodenals are more difficult simply because of their location. Important, differentiate free air from bowel gas. This is very difficult. I'm back to that point. So you have intestines all over the place, and of course, some of those intestines are right up against the abdominal wall. And as the patient's laying down, so you go through abdominal wall, parietal peritoneum, and then you go pretty much directly into visceral peritoneum and intestines. And so air in the intestines can look like it's right underneath the parietal peritoneum. Our job when that happens is really to try to figure out, move the patient or just sit there and watch and see if any kind of peristalsis occurs and moves that gas. Because if that gas is actually in the peritoneal cavity, that shows that there has been a hole in the GI tract and gas is actually making it out into the peritoneal cavity. And if gas is making it out, then you could better believe that bacteria and stomach and duodenal GI contents are getting into the peritoneum, and that's very dangerous. Yeah, endoscopic ultrasound would be far better served, would be a better way of really looking at this. But here, once again, this is stomach. It's got to be stomach because we have left lobe of the liver, and that's where the stomach, this posterior. That other picture, the stomach was over here, so it was inferior, right? Posterior, inferior. All depends on where you are. Longitudinal image demonstrate gastroenteritis, a patient with air-filled benign gastric ulcer. Benign, but painful. So here's this ulcer here. This ulcer has a little bit of shadowing, and they're calling it air-filled. And that maybe it is, though that type of shadowing is not the type of shadowing you get from air. So I'm a little dubious on whether that's truly air or that is air there. Maybe it is. I've been fooled before. Ulcer. So remember, ulcer, and did we mention what causes ulcers? Well, so an Australian doctor, 20 years ago, had a theory on ulcers because they used to say ulcers. Well, that was just stress caused ulcers or bad luck or genetics. And he drank a solution of bacteria, H. pylori, and he got a whole bunch of ulcers after drinking that. Fortunately, he was able to reverse the process, I believe. But so gastric ulcers are more likely to be caused by just a little bit of a particularly vicious stomach bacterium. Crohn's disease, idiopathic, meaning we don't know, we're idiots, we don't know what causes it. Excuse me. Inflammation starts at the submucosa and spread to all layers. Mostly affects the terminal ileum and proximal colon. So as the intestines go round and round and round and round, it starts with jejunum, turns into ileum, and I don't know why they all look the same to me, honestly, but the ileum and the colon definitely look different. And so the ileum goes into the ascending colon. It's at the cecum, but we'll just say the ascending colon. That's where it usually occurs, in that area, but that doesn't mean it's the only place. Other parts of the colon, small intestines, even stomach and duodenum in some people. So time of diagnosis, the entire wall is involved. I've seen Crohn's disease a number of times. It's pretty easy to see when it's right there in front of you. Chronic inflammation causes hypervascularity in the wall. Remember that other term, hyperemic. Carcinoma, lymphoma, hematoma. Yes, we could actually bruise our intestines, and tuberculosis can all have similar appearances. But this is a cool picture here. You could see this is an extremely thick wall, thick wall, thick wall, thick wall. And then, let's see, that's I'm just trying to, I'm getting some landmarks here. You know what, that is large intestines. This is probably the terminal ileum right here. Hopefully you guys can see that. Because that's a small intestine here. I actually thought when I first saw this that this was all supposed to be that size, and this was the amount of swelling. But now I'm realizing now that's terminal ileum. Maybe even the appendix, actually, because that's where the appendix is, right in this area too. But and then this looks like, appears to be ascending colon. I could tell from the structures down here. It looks like this is down by the hip bones. Extremely thickened layer and very hyperemic blood flow. Transverse view, bowel, Crohn's disease, yeah. So nice. I didn't mess with this one, but I left it up. Stomach infection display marked thickening of wall and gastric rugae. Rugae are the larger fingers of tissue entering into the stomach. Phlegmon, gastritis, and so the entire area is edematous. So hemolytic streptococcus, staphylococcus, E. coli, which is what we all have. Actually, we all have staph as well, but E. coli is normal, but sometimes not so good if it infects the walls. Clostridium welchi, Helicobacteria pylori, and Proteus and other Proteus species. We don't have to memorize that. I just left it up there. Peritonitis. I have to go back to the book. 70% of cases of what? Just peritonitis, just in general with inflammatory diseases, I guess. So peritonitis, that means the bacteria got out of the intestines and into the peritoneal cavity. Gas-forming organisms can cause small gas bubbles to form in the gastric wall. And so on CT and X-ray, well, CT especially, they'll actually look at the intestines and see air is very obvious on CT because it's actually black on CT. For us, it's white. CT, it's black, and you can actually see it. And with us, it would be a little difficult considering the lumen is filled with gas. But if you were able to see an empty lumen when then it would appear to be air in the walls, then that would be a great find, kind of a once-in-a-lifetime find. But. So that's called emphysematous gastritis, is when organisms that can create air are in there. All right, just a little bit longer here. Benign tumors are mostly asymptomatic. Polyps Gastric adenomas, polypoid masses, just means anything that looks like a polyp. Adenomas have some malignant potential. Lipomas, just like lipomas in the liver or even the spleen, lipoma or in the soft tissues, lipomas could also occur in the stomach and GI. And they are typically echogenic, no matter where you see them, unless the surrounding tissue is echogenic. Smooth muscle tumors, gliomas, to show a swirled texture if they are large enough. And that's also sometimes typical on uterine fibroids. You could actually see muscle in a swirled pattern sometimes. All right, where are we going here? Carcinoma, just quickly. Let me just finish up with carcinoma and I'll let you take a break. Adenocarcinomas. Leading, I was going to say it's it's a leading cause of cancer-related deaths. 50% cure rate for localized early-stage disease. So that's why doctors, when you're older, they start checking because if they catch it early enough, or even if they catch the adenomas or the polypoid adenomas before they turn into cancer, then you're really in good shape because it never had a chance. So one reason why these guys can grow for a while before you notice anything is that they oftentimes will grow exterior to the lumen. So if they're on the outside, the stomach or the duodenum or whatever it is continues to do its job, even though this mass is growing. Eventually it'll grow large enough to cause problems. But that's kind of the problem with this type of cancer, is that it grows on the outside, or oftentimes grows on the outside, allowing you to live your life, and then suddenly you find out you have stage 3 cancer. Okay, we'll stop on lymphoma. Oh my gosh. Well, all right, yeah, let's stop on lymphoma. Let's see, it's 2 o'clock. Let's go ahead and take it. I need a 15-minute break anyway. I'm pooped. All right, 15-minute break, guys. Thank you. So this is weird. I had to look it up because I did not know this. Because lymphoma, whether we're talking about Hodgkin's or non-Hodgkin's lymphoma, those are just two sides of a lymphoma coin. And it really just depends on which cells have gone cancerous. They are white blood cells, and they're part of the lymph system. They're white blood cell kind of macrophages of the so they could spread through the lymph system, through the blood. And then there's H. pylori, which is a stomach bacterium, and I had no idea that H. pylori not only can it cause ulcers, but it actually can cause a lymphoma, so a primary lymphoma of the stomach. So, in other words, lymphoma that started in the stomach could actually be caused by that. New for me. Click on that. So in the realm of lymphoma, there's a number of different subcategories. Reticulum cell sarcoma and lymphosarcoma and then Hodgkin's are all subcategories. Ultrasound, we're going to see obviously a thickened wall. That's hypoechoic wall, marked rugal thickening. Um, more gastric carcinoma is more likely to be more echogenic than lymphoma. Like I said the other day, lymphoma, no matter where we have it, tends to be hypoechoic. So if you see almost a cystic structure with zero or no through transmission, now you have to think, oh, that might not be a cyst, and wait a minute, could this possibly be a lymphoma or other type of metastasis going on? Gastrointestinal stromal tumors or GISTs, they're benign or malignant. They start from the interstitial cells of, now being in El Paso for the past 3 years, I want to say Cajal, but then I was like, wait a minute, or is it Cajal? I don't know. It's funny how my pronunciation of words has changed in 3 years. But I will just say Cajal for the heck of it. Those are, let's see, I wrote it down. Yeah, they are kind of like, they're a little bit like nerve cells. They help tract or send signals through the muscle for peristaltic motion. And so that's where the GIST tumors come from, is those particular cells. A uterine fibroid is similar. Sorry, I can't read this. Uterine fibroids look similar to that, and they have a similar cellular structure as well. Yeah, that's right. The benign counterpart, the leiomyoma. So fibroids and leiomas, leiomyoma is the same thing. We only call them fibroids in the uterus. Everywhere else in the body, they're leiomyomas. And sometimes in the uterus, they're leiomyomas. But we have to have several words for everything just to confuse issues. Some people say all of these cancers or all of these growths will become cancerous. Others say that the small ones will not. Hemorrhage and cystic degeneration, which is one and the same, really. If you have a tumor that hemorrhages inside of itself, it's going to look cystic. That can occur. I just left this one up here just to leave it there. We could just to know that other malignant gastric lesions, and I'm not even going to go through them. So looking at the duodenum, remember that's the first part of the intestines, or duodenum. I prefer duodenum. Is best visualized by examining before and after ingestion of water. Valvulae conniventes, and that's why I say the folds inside the stomach are not necessarily the same name as the folds elsewhere inside the duodenum, and other parts of the small intestines, but not all of them. I think the jejunum have valvulae convenientes. These are folds inside the bowel wall which microscopic villi protrude. So what we're seeing here are macroscopic folds. These are the valvulae convenientes. And then on a microscopic level, each one of these has thousands of little microvilli. And that's when I say that you could stretch out the intestines. If you were to stretch it out entirely, it would cover a football field. So first portion is the duodenal bulb. That's right to the right of the gastric antrum. Well, it has to be because that's where it starts. And so gastric antrum / pylorus muscle. Anterior superior to the pancreatic head. Yep, it's right over the head. That's what makes seeing the head so difficult on the pancreas. Stomach makes the rest of the pancreas difficult. First part of the duodenal bulb makes the head difficult, and medial to the gallbladder, sure. shortest portion, only a couple centimeters long. The second portion is descending. That's kind of that C curve or the downward part is to the right of the pancreas head. Yeah, to the right to the pancreas. Oh, and then third portion that comes around the corner. So if we can, so here's the first portion only from here to here. And then the second portion is the descending. Third, as it turns the corner, that's the C, they're called that C loop. Duodenum, next question. Yep, and then the fourth, they call it ascending, but it really just barely goes uphill or barely ascends before going down and then turning into the jejunum or duodenum, whatever. Ulcers in the duodenum are more frequent, although harder to see. Bleeding, perforation, obstruction, even from so much swelling, can occur at the duodenum or outlet of the stomach. Perforation, of course, could cause pneumoperitoneum, air in the peritoneum. Oh, that was another picture I should have grabbed. So on this patient, this is normal. So we have, let's see, sagittal liver, really? Okay, yeah, okay. You could see a stomach wall. It turns from stomach in the duodenum at some point here. And you can actually see some of the layers, not all of them, but some of the layers, the hypoechoic and hyperechoic layers of the duodenal wall here. And then there's gas. So we at least know that the gas is where it's supposed to be. That's inside of the intestines. Small bowel, obviously drinking water, but you're going to have to wait. So drinking a lot of water and waiting for the patient to pass that water into the small intestines could help demonstrate peristalsis and see everything a little bit better. If ileus or obstruction is present, taking additional fluid by mouth is not recommended. So these people, if you give them anything, it comes right back out. So be careful. No, I'm not going to tell that story just yet. I'll tell it when we get back. Yeah, the small bowel is distended. You can see the valvulae covenantes and everything. So I personally don't, well, if they're filled with fluid, you could see a difference in the internal anatomy of the jejunum and ileum. But other than that, I really don't know the difference, other than the jejunum's more likely to be high up in your belly and the ileum is more likely to be low in your belly, because that's where the small intestines end with the ileum. Bowel sections, pliable in palpation. Peristalsis should be visible. Maybe not crazy. If there's no food in there, peristalsis could be very light. If fluid is present, then once again, we see those. And with ascites, obviously, we're going to see everything beautifully. This is a pretty amazing 3D image of the small bowel there. Here's an interluminal image. So let's see that. Yeah, so a transvaginal image here, looking off to one side or the other, and you can see intestines going. Actually, yeah, so we can see intestines there. And let's see, transverse image of normal descent and not small bowel. Okay, normal small bowel down here as well. Actually, this is probably the same patient. Very likely the same patient. Yeah, it is. So in other words, they were probably, yep, they were sagittal on this picture, and then they went transverse. So This is what the bowel looked like in sagittal. The same bowel, when you go transverse, now you're only seeing one thin section of it, and there it is right there. There's those valvulae convenentes. Ileus. AKA for ileus, acute intestinal pseudo-obstruction. So an ileus has diminished motility. So there's obstruction is obstructive. Volvulus obstructs from twisting. Ileus has the appearance of obstruction, but it really is actually a matter of no peristalsis, and so fluid and fecal matter are just hanging out and not moving through the body or through the intestines. So that's what ileus is really diminished motility. Back to obstruction, adhesions, in other words, scar tissue, volvulus, spinning, torsion, I should say. Inflammation can really thicken. We saw that Crohn's disease. That was so thick that food, fecal matter would have a very hard time getting through that. Intussusception. Oh, we haven't talked about that one yet. Neoplastic lesions, luminal obstructions. Okay, so intussusception. Well, I got a couple pictures on that. I think we actually towards the end we do talk about that. This is something we generally see in children, young children. Just more images of obstruction. Every time we see fluid in the intestines doesn't mean there's an obstruction. It could just mean you have diarrhea. Here we go, intussusception. Telescoping of bowel into an adjacent segment. More common in children, and in the setting of an adult, it would have a tumor or really a pivot point. So in children, how do I explain this? Okay, so we have a couple of pictures. You have a nice long sock on. You go to take that sock off, you push it down your leg, and it partially rolls up on your leg, and by the time it gets off your foot, it's kind of rolled around itself. And instead of being a longer tube, it's now a tube within a tube. That is what happens, and I hope that made sense. That is what happens with intussusception. A segment of bowel telescopes or slides into an adjacent segment of bowel. It sometimes happens at the ileocecal junction. So the ileum, where it goes into the large intestines, it can just slide in. Now, nice thing with children, all you need to do to cure it is a enema, and that kind of blows it out, pops it back out, and that's usually all you need. In the case of an adult, a tumor, that does not normally happen in an adult, but if it does, it's probably because a tumor, something hanging on that intestine, weighed it down and pulled it into the other part of intestine. So it's a lot like taking off a sock, and it's kind of halfway rolled up around your foot as you pull it off. So bowel appears as concentric circles on a transverse plane. Sometimes they call it the pseudo-kidney sign because it has a kidney-like outline, and it has been actually confused as kidney in the past. A and B longitudinal images. Well, I don't know how longitudinal they are. This one certainly looks transverse. But on this one here, the second one, there's actually a loop of bowel sitting inside of another loop of bowel. There's fat. Well, we have fat around our intestines, and so fat has been pulled in. This is most likely what appears to be an ileocecal intussusception. And the only reason I know that is because this loop of bowel is much bigger than this. The diameter is huge, and that's likely because this is large intestine. This is the very beginning of the ascending colon is called the cecum. That's why they call it a cecal. And so this is small intestine sitting inside of large intestine, and it brought some fat with it as well. This one's a little harder to see. This one may not be ileocecal because the two sizes are not that much different. So that's intussusception. Hematomas are, well, sometimes a trauma, as in like a hematoma from getting punched or a car accident. They can actually happen with the bowel. These other, everything that says purpura. This is Latin for purple, and it kind of means hematoma. And there's different disease states that just kind of causes it without trauma. And so those three states cause the bruising without trauma. Ischemia, lack of oxygenated blood, medication, hemophilia. I think hematoma would be very difficult for us to see. But if you do see nonspecific wall thickening in a certain area, then you could be looking at hematoma, although I don't know how you would, other than knowing that the person had an accident, like in trauma. In the case of trauma, I don't know how you would actually know. Crohn's disease, inflammatory bowel disease, most common reason for performing a small bowel sonography, and most common non-specific small bowel inflammation. And like I said, you will occasionally find Crohn's disease on people, whether it's sometimes Crohn's comes and goes, but you'll always be able to see it. Most of them in the small bowel, ileum in particular, large bowel less common. All right, we already talked about some of this, bowel thickness. And well, let's go back to that. Various published reports considered normal wall thickness is 1.5 to 3. So beyond that, we have thickening. This image, I guess this is lumen here, from here to here. So that means from here all the way out to here is wall. That's very thick. And here we can clearly see a very thickened wall as well. Other small bowel tumors, smooth muscle tumors, those are leiomyomas actually, the carcinoid tumors, adenocarcinomas, lymphomas. So the chapter does this. It kind of starts talking about something and goes away and comes back. So we're back to lymphomas again. But lymphoma, most frequent, most of the bowel is usually part of a systemic involvement, most frequently by non-Hodgkin lymphoma. You could have a target lesion when you look at it in transverse, the bowel, not necessarily the body. Mesenteric nodes may also be affected. So in other words, your lymph nodes are going to be increased in size. This little note here. Okay. Primary adenocarcinoma could be circumferential, going all the way around, or more polypoid on the outside. Those polypoid ones, those are the ones that are going to hide longer because they're not causing a problem. A constricting circumferential lesion, that sounds worse, and in a way it is, but you're going to know about it sooner, which gives you a better chance of living. So if you're going to have them, you'd prefer circumferential. Leiomyomas, once again, these are benign from the muscularis because they are a muscle tumor. They used to think that leiomyomas could lead to leiomyosarcomas, and actually they really found that they don't. Leiomyomas stay leiomyomas, and leiomyosarcomas always were sarcomas from the very moment they were formed. Larger tumors and tumors with central necrosis are more likely to be malignant. So when these things are growing, when they grow fast, they're more likely to be malignant. Central necrosis, in other words, when you look at this, it's going to be hypoechoic fluid center. And not like a donut, well, a little bit like a donut, I guess, but those are more likely to be cancerous. Other tumors, adenomas, lipomas, hemangiomas, and neurofibromas. So I had this was so bad. I might have told you guys this one, but when I was a student, I had a lot of difficulty with the kidney. I just had a real hard time understanding how to image the kidney. And I've been working on it with this one preceptor out in the field, a nice guy. And I go in to see a patient, and he has neurofibromatosis. And I'm sorry if anyone's family members suffer from this. And it's not. I wasn't really making fun of the person. I was jabbing at my my preceptor. People with neurofibromatosis oftentimes will have neuromas, tumors all over the body, like pom-poms all over the body, especially the abdomen where they're largest. And so I go in, I do this kidney exam, and I come back out, and he says, "How'd it go?" I said, "Well, he just had this one skin tag, right where I needed the scan." He said, I just couldn't get around it. And my preceptor rolls his eyes. He's like, "Kurt," and I see him step. I see him step into the room, and this poor man is sitting there with at least 800 tumors on his body. They're benign tumors, but obviously problematic. And my preceptor just stopped in his tracks, stood there for a second, regained his professionalism, did the exam, came back out, and as we're walking out the door, he just looks at me and says, "You SOB." I told him one little skin tag was in my way. Anyway, that was just a little aside, just for the heck of it. So anyways, metastatic malignancies, especially from melanoma. This melanoma is all over the place, is it not? And carcinomas of the lung, kidney, and breast can also go to the small bowel. Technique. The appendix, right. Right lower quadrant. In fact, let me, actually, no, I put the picture there. I did, okay. By placing steady pressure on the transducer, one can displace gas. Okay, that's anywhere on the intestines. Don't be afraid to push as long as you're not pushing on a rib. Don't be afraid to push. Cecum and terminal ileum can often be seen. Oh, you know what? I've got a video. One can identify the normal appendix. In some patients, only inflamed distended appendices can be visualized consistently in the adult population. Hopefully in little children, we can see them a little more often. Can you guys, hopefully you can see us a little bit better. I've got something at the bottom of my screen. McBurney's point is, if you draw a line from the umbilicus to the iliac wing, the hip bone on the front of your body, 2/3 from the umbilicus is McBurney's point. That's where the vast majority of appendices will be found. Normal, not routinely visible. These are it's intestines. It's a needle in a haystack, or really more, it's like a needle inside of a needle stack, because everything is intestines, including the appendix. So very difficult to see. Ascites, oh, it makes everything pretty. Tubular structure attached to the cecum. The cecum is the very first part of the ascending intestines, the ascending colon, with a closed blind ending distal tip. So that's one thing we do. We look for that distal tip, and if we find it, then we say, absolutely, I'm looking at the appendix. It does not peristall. It may be jostled around by other loops of intestines, going through peristalsis, but it itself does not go through peristalsis. It just lays there. It should measure no more than 6 millimeters in outside to outside diameter. The hypoechoic part of wall should measure no more than 2 millimeters. So that hypoechoic part is the part that's going to be thick with appendicitis. Transabdominal, we scan the ascending colon transversely from hepatic flexure to ileocecal valve. Now, we're going to look at this video in a second, and that's going to, you're going to understand this a little better. So we scan the ascending colon. Well, the ascending colon doesn't look like anything to us, but that actually works to our advantage. We go transverse on the ascending, we start up a little high, and we just work our way down. And you're going to know you're on it, because 9 times out of 10, it's going to be filled with gas. If it's not filled with gas, then that's even better, but it usually is. When it ends, when that gas pattern ends, you just went off the end of the colon, and so you're basically at the cecum. At this location, if you look carefully, you should be able to see the appendix and also the ileocecal valve. In other words, where the ileum goes into the large intestines. Graded abdominal depression, an endovaginal approach may be combined with transabdominal approach to increase success rate of diagnosis in female patients. Maybe. Here, do I have that still? Okay. If someone doesn't, you guys don't see it well, just go ahead and let me know. With the right upper quadrant, we like to look at the gallbladder since it's right up there. Make sure there's no stones. We look at the right kidney and the liver. Make sure there's no fluid in Morrison's pouch. If there's a ruptured appendicitis, you might get fluid up there. Once we establish that, we go a little bit down, and right here you have the ascending colon. Usually you're just going to see a pocket of air in that region. Over here you see the iliac artery and iliac vein. Scan a little bit down, and then right here, just below the cecum, you have the appendix. As you see, this is appendix right here. This is appendix right here as well. And also this right here. So these 3 circles, that's the appendix. And that was really good of this guy to do that, to show how you see 3 different circles in one appendix, because it's tortuous. And there it is again. There's a
tiny bit of free fluid. It was about 3.5 millimeters, normal. Over here again, you can see the iliac artery and iliac vein.
So yeah, vein, artery, and this muscle right here is the psoas muscle. And what oftentimes happens is that most of the time is that the appendix kind of lays over this muscle. So finding this muscle is also a nice little technique.
Just posterior to it, you have the psoas muscle. And then this is the sagittal. As you can see in slow motion, this appendix is very serpentinous. And you can see these echogenicities within it, and that's air. You don't always see that, but you can see air in the appendix. Here's the tip. So you can sometimes see a little bit of fluid or, material within the appendix as well.
Oh, wow. So fat stranding, that's actually a CT term the radiologists use, but we see it. We see fat in the area of the appendix is going to be more echogenic, more thick than usual. Oh, right. I haven't even read the fat hyperemia. Appendicolith, if you actually see a stone inside the appendix, some people say that it's automatic appendicitis, and obviously he says in some normals it's not appendicitis. So, but it is strongly associated with appendicitis, the appendicolith. Any kind of fluid around the appendix is very suspicious for rupture or just exudate, just fluid squeezing out. Ooh, mucocele, I think. So yeah, appendicolith. Now my eyes are going to this. What am I looking at here? And maybe a little bit of fluid outside of the appendix here. So this might have burst a little bit. And certainly the continuity of the wall seems to be questionable right here. And this is filled with a mucus type substance. So that is a special kind of appendicitis called a mucocele, and potentially a lot more dangerous. Oh, okay. All right, short and sweet. Why? All right. So nice normal appendix. See, it's sitting on top of the muscle here, the psoas muscle. Really, really nice thin there. Blind end. Oh gosh, that's hard to see. I'm going to track it like this. It's actually going over the iliac artery right here. So it's a little bit of a lump right there, and then it ends. Now it's really hard to. You have to find the actual end. Remember, your intestines are all going in every different direction. And so when you follow something, sometimes you'll be sagittal on it, then transverse, and then and then it's gone and it's back. So you got to find that blind end and then go off it you go off it in several different directions to make sure that it's actually not just a normal loop of bowel that turns sharp at that point. And it's very easy to confuse that. So the vermiform, vermi means worm-like in Latin. Projection from the apex of the cecum, most common surgical emergency, 7 to 12% of the population, usually on the younger side, but you can have any age. Leukocytosis, in other words, white blood cell count is going to go up, your fever is going to come around, and nausea and pain. Rebound tenderness. There's a special kind of tenderness. Yes, it hurts when you push on the appendix. It hurts worse when you release that pressure. So you push down and they're like, ow, and then you release, and then they're screaming. So it's a little bit backwards, and that's rebound tenderness. Yeah, sometimes appendicitis is totally missed because the people's symptoms just don't follow. CT is better, but especially with children, they want to avoid all that radiation, so they'll send them to us. Non-compressible. So what we'll oftentimes do is a dual screen. On one screen, we're not pushing. On the other screen, we're pushing. And if the diameter doesn't change or changes very little, that supports appendicitis. Because if you push and it squeezes out, then it's probably not appendicitis. Retrocecal appendices or appendices are difficult to visualize sonographically. In other words, the appendix is not in the same place every time. If it goes behind the cecum, cecum's filled with gas, we're going to have a very hard time finding it. Pendicolith, strong indicator. Hyperemia, due to inflammation, is a strong indicator. Endovaginal sonography places a transducer in closer proximity, therefore increasing diagnostic ability or yield. Nice thing about endovaginal is that you kill two birds with one stone. You look at the ovaries, which are also, see, we miss appendicitis in women, young women, more often than in young men, because we automatically, or the doctors automatically think ovarian pain. And so for that reason, we miss it very often. Appendiceal abscesses, so the bacteria growing inside the appendix can make it through the wall, either through the exudate or right through a perforation. And because of that, you have an abscess. A tubo-ovarian abscess is different, totally different. That is a obviously female issue where it's basically pelvic inflammatory disease. So the abscess usually at the tip, but can be found in other locations. This appendicitis at the top is not terribly obvious. It seems a little thickened, certainly a little round and a little more obvious than most appendixes, but I'll tell you what, guys, I sent a young person to surgery who had an appendix who looked similar to this. The radiologist agreed with me. He called it appendicitis. They went to surgery and it was not appendicitis. So this one looks like it, but I would be careful. I would do a lot more looking for hyperemia, fluid, appendicolith, any kind of fat in the area, fatty stranding or echogenic fat. Without any of those other things, I would be very cautious about what I would say to the radiologist, because the pediatric radiologist looked at the images the next day and said, "Oh yeah, no, that's not appendicitis because there was no fluid, there was no fatty stranding." Well, mistakes happen, and it was a lesson learned for me. Down here, this one, let's see. This one's a definite thickening and definite filled with a more of a mucoid type fluid. And a lith, appendicolith, is shadowing here, and certainly appears to have increased blood flow. So first two, not A and B, not so sure. So the mucocele, distension of appendix by mucus, uncommon, but here's the thing, these mucoceles can be a form of mucinous cisadenoma, or worse yet, mucinous cisadenocarcinoma. And I love this, I don't understand this line. Mucinous cisadenocarcinoma is considered to have malignant potential. As I understand the word, that is malignant. Cisadenocarcinoma is malignant, so I'm not sure. Or maybe I wonder if they meant it has potential to metastasize. I'm not sure. So very, 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 very rarely your appendicitis could actually be a mucinous cisadenocarcinoma, but that's extremely rare. Mucocell rupture can cause massive accumulation of gelatinous ascites, also known as pseudomyxoma peritinae. Pseudomyxoma peritinae, gelatinous ascites. Now, interestingly enough, carcinoid, even though I just said carcinoma is pretty much, that's always cancer, carcinoid is not. Carcinoid tumors appear as sharply marginated hypoechoic masses without acoustic enhancement, small, larger lesions are more likely to metastasize. 1/3 of all lesions will have nodal or distal metastases. Okay, come on. Carcinoma has been reported. Medical medicine of acute appendicitis. So other disorders: adenocarcinoma, Crohn's disease of the appendix. Sonographic non-specific. Enlarged lymph nodes adjacent to cecum may be observed with bacterial ileocolitis and or mesenteric adenitis. Right lower quadrant lymphadenopathy, your increased size lymph nodes without associated appendicitis, is mesenteric adenitis, and the most common diagnosis at surgery if appendix is normal. Okay, I'm just kind of getting an idea where we are because I was really hoping to finish this today, but I'm not so sure. Colon and rectum sonographer may have difficulty differentiating a solid colon mass from a small bowel lesion. Helpful to know where the colon is located. So I went a long time as a sonographer without really paying a whole lot of attention. Once you start paying attention, it's actually very easy to understand where the colon is as compared to small intestine. Even if they're both filled with air, you can clearly see the difference. Colon often folds 3 to 5 centimeters long. Yeah, I'm gonna skip over that. Normal colon. So here's a colon without gas. That's normal. It doesn't always have gas in it. It usually does, but not always. Here's colon with gas, and you'll see one of the things that shows that it's colon is goes bloop, bloop, bloop. These are haustral folds of haustral folds. I just want to make sure I said that right. So, you know, in the colon, boom, 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 and each little lump has its own little gas inside of it. So that is, and here again, haustral folds could actually be seen in that gas. Ulcerative colitis, longitudinal colon, thick hypervascular wall. Patient diagnosed with pancolitis. In other words, all of the colon has colitis, pancolitis, a severe form of colitis that involves the entire colon. This is a young woman, and the poor thing. This is horrible, by the way. Any Crohn's disease, anything going on with your intestines is a pretty horrible feeling. Diverticulosis, I've definitely seen this in looking for, usually in females, because we're doing a pelvic ultrasound and we're looking for ovarian issues. But occasionally you'll actually see the descending colon, sigmoid colon. Sigmoid is as it comes across towards the belly button. So it's descending down the left side of the body, sigmoid as it comes across. And I've definitely seen diverticulosis in those sections. Yeah, that's rectosigmoid colon is most often affected. 50% of people older than 50 have diverticulosis. Now, diverticulosis is not the problem. Diverticulitis, that's the problem. Results if one or more diverticula become filled with insipid fecal material and then becomes inflamed. This inflammation is actually similar to appendicitis. You know, there's the fat stranding around the outside, maybe some fluid on the outside. So inflammatory thickening, pericholecystic abscesses may form because of transmural spread of infection. The bacteria in this area actually make it through the wall and outside. Diverticulitis, multiple myasthenia. So I got it backwards here. The intestines here are the more echogenic, and so it's sticking out, sticking out, sticking out. There's 3 diverticula in a row. I don't necessarily agree that this is diverticulitis, though. I don't understand. I don't see thickening of the wall. I don't see echogenic fat on the outside. I don't see fluid. So I think this is diverticulosis, not itis. This one's interesting. It certainly appears like it's been, like there's a hole. However, if that were the case, boy, it would be obvious. So I'm not so sure if this is truly a hole in the wall or not, a perforation or not. There seems to be wall thickening on this one, so maybe that one's a little more likely to be diverticulitis. Although I'm I'm not so convinced. I'm not convinced on any of those, honestly. Uh, 50% of colon carcinomas arise in rectum and rectosigmoid colon, which is why, oh God, I just turned 50. Actually, my doctor does not do the digital exam. Oh, baby. 25% of sigmoid, 25% of rest of colon. Transabdominal sonography demonstrates a large colon cancer as non-specific hypoechoic target lesions. Smaller polypoid lesions are much more difficult. Cecum, so this is the other end of the large intestine. There's a colon carcinoma mass there. Ultrasound here, and then in CD, this is a air contrast barium enema displaying the same sigmoid colon. Air contrast. I don't know how the air contrast and barium at the same time work, but you can see that fluid is having, and these are the Hostra folds, but then the fluid is going through almost a stenosis here this is the enema, is going through a stenosis here. And so what we're not seeing is the tumor encircling that. And here is the actual tumor on the person there. Endorectal probes or transducers are obviously going to see this in much greater detail than we can see with our transabdominal. It looks like, just so you know, actually, this is the transducer face here. And what they have is a large, they have a fluid inside of a condom here. So they're using that fluid as kind of a standoff pad. Remember, you don't want your transducer too close to what you're looking at. And so that's what it appears to be. Here's a transducer, and they do the orientation is upside down. I guess because you're going through the back. But anyway, so here's, thickened rectal wall there. Stages. Stage 1, cancer through muscularis. Stage 2, cancer has grown into outermost layers of colon or rectum or through the wall of colon or rectum. It might be attached to or has grown onto other nearby tissues. So that's kind of a large stage 2. Stage 3, cancer in nearby lymph nodes. And stage 4, cancer has spread, has metastasized to other organs. Jesus, I feel like we're going in circles. Lymphoma, similar to lymphoma, small bowel, most likely hypoechoic, just like everywhere else lymphoma is found. Can be annular, eccentric, or diffusely involved in the bowel. So diffuse means all over. Eccentric and annular seems like the same thing. And annular goes all the way around. And eccentric, I think, goes partially around. Same lesions can be seen in colon and rectum. So leiomyomas, lipomas, fibromas, hemangiomas. Ah, good. Good, guys. We did it. So, target or pseudo-kidney sign, circumferential hypoechoic thickening of the bowel wall. So all the way around. That could be lymphoma. It could be intussusception. 2 loops of bowel or 2 sections of bowel, one inside of the other. Just inflammation in general, chronic ulcerative colitis, in other words, Crohn's, regional enteritis, which seems like it would be Crohn's, but it's not. It's a little bit different. Hematoma, okay, and metastatic tumors. Focal hypoechoic lesions, neuromas, fibromas, gastric cysts, varices, ectopic pancreas, Where did they put? I will add lymphoma because that's the whole focal hypoechoic lesions are oftentimes lymphoma. Focal hyperechoic lesions in submucosa are still, oh, no. Ectopic pancreas. Remember we learned that that could actually happen. Lipomas, hyperechoic. Lipomas tend to be hyperechoic. Focal defect in gastric mucosa with mucosal layer preserved to edge of ulcer. So that kind of gives it away. Benign gastric ulcers. Defect in gastric mucosa with indistinct mucosal layer at ulcer edge, benign or malignant ulcer. Focal hypoechoic lesions of muscularis propria, leiomyoma, leiomyosarcoma, or metastatic tumors, large cystic lesions, obstruction, ileus, volvulus, mucocele. The obstruction, the ileus, and volvulus are all just fluid inside of the intestines. A mucocele is more likely to be a appendix, thickening of the valvulae in small bowel, cirrhosis, renal disease, oh God, Whipple disease, lymphangiomatosis, the entire alphabet, proteinemia, and inflammatory disease. Mild thickening of the colon wall, ulcerative colitis, regional enteritis, diverticulitis, pseudomembranous colitis, amoebas, shigellosis, which is a bacterial radiation colitis. So people who receive radiation therapy have damage to their cells. And then multiple concentric rings of bowel intussusception. We did it. Yeah, I'll save whatever I did there. Oh, okay. So there's an intussusception right here. That looks like the picture you've already seen. I just want to, before I let you go, guys go, I want to look at this CT, where this person, you could see, even though we're not experts, you could see that maybe something's not quite right with these intestines. They seem to be really filled with fluid. This is, oh, we're all the way down. I was wondering where we were. We're down pretty low. The reason why we see two aortas is not because they're aortas. It's because these are the iliac arteries. They just bifurcated down here. So this is down maybe about belly button. But this vessel right here is the superior mesenteric artery. Now, the superior mesenteric artery typically does not do a loop-de-loop. Does not do that normally. This is all SMA. Once again, this one's doing a, let's see, probably come around that way, a loop-de-loop. And that loop-de-loop looks like it's going in the opposite direction as the one above. This here is called the whirlpool sign. It is a sign, is an indication that you may have volvulus. So one of the things, okay. One of the things, and this is what happened to me actually. So this patient, their intestines are spinning, and at the very top of the SMA stays put. what actually happens in development, we'll talk about this later, is the SMA kind of like right dead center. And early in development, the intestines do, they spin around, they spin around, and they spin around. They spin around like 360 degrees. I think it's greater than 360 degrees. And so our intestines have a natural spin, but that natural spin is centered on the SMA. It's really cool. So that's why the SMA is always going to be in the same spot unless there's valvulus. So in this person, SMA was going along fine, and then what's happening is that it's taking a sharp turn and spinning around. So this person's intestines have unnaturally spun around. So we get the whirlpool sign. The other thing that could happen, if you don't have a full-on whirlpool sign, remember when we see our it's too small. Let's give ourselves, get my little cheat going here too. Our aorta, and then there's like an IVC over here. It's usually kind of flattened out. The SMA is more or less over the aorta. Oftentimes a little bit off to the patient's left, could be over here, but it's more or less somewhere between, in this area, anterior to the aorta. Now, I actually have seen an SMA that was all the way over here, and what that was indicating to me is that there was something to be found. And sure enough, what I found on this patient was a large renal tumor. So let's say, that's not going to work. Well, a renal tumor, a very large tumor, was pulling down on the intestines. And so the SMA was pulled around in that direction. So the SMA is so reliably in that one location, and it has to be because of the way we develop. There's really no other choice. If it's not from here to here, anterior to the aorta, something is going on. And so it could be spun all the way around, or it could be, like I saw it pulled over here. In the case of the whirlpool sign, let's see, let's do that. What we could actually see is what happens is as it's coming down the body, it starts spinning. It can't go behind the aorta. That would be impossible. But what it can do is spin around like that, and all the intestines are going with it. So whirlpool sign is a great, great sign for us to notice. And up here, we can see the whirlpool. But this one, well, let's see. Everything's being spun around. Actually, no, I think it is spinning that direction. So it's going around that way. Interesting. In any case, on CT, that's a sign of volvulus. Ultrasound, sign of volvulus. Pull that note down. That up real quick. Okay, just did a whole chapter. Not too bad. Nice when we get a whole chapter out of the way. You guys were real quiet today. I have a hard time with PowerPoint. I tried to keep it halfway decent, but thank you for sticking in there with me. And I mean, I wouldn't know it if you all fell asleep. But. Any questions? All right, test on